So it's really a pleasure and an honor for me to introduce this next topic, which is on managing adults with spinal muscular atrophy. And I'm excited to hear the presentation from two members of our team here at Stanford. Connie Wolford is the neuromuscular nurse practitioner who has tremendous experience in treating and managing these patients. And we'll also hear from Jacinda Sampson, a neurogeneticist in our neuromuscular program, who's one of the people that we stole from Columbia. And we've just hired another physical therapist from Columbia, so we're keeping that connection strong. So at any rate, it's great to have you here, Connie. So thank you very much, and take it away.
All right. Thank you, John. As he said, I'm the neuromuscular nurse practitioner at Stanford, and I run the adult Spinraza program here at Stanford. I have no disclosures, but I do have to say that it is a bit intimidating to be speaking before this expert panel, folks that are experts in SMA, so I may actually just kind of divert my eyes from the first two rows of the audience on the left here. They've asked me to talk about chronic health management of the adult living with SMA, which is very different today, obviously, than it was just 3 years ago with the approval of nusinersen or Spinraza. Since Spinraza was approved, according to manufacturer, about 7,500 adults have been treated worldwide. Roughly, or close to 1,000 of those are adults in the United States. What we found in our center, and I suspect others did as well, was an influx of adults after Spinraza was approved by the FDA. And what was interesting is that so many of these patients had not had any health management for sometimes decades. No primary care doctor, no health maintenance, no preventive health care. We had folks with blood pressures that were wildly uncontrolled, sleep-disordered breathing, body braces that are 30 plus years old that were being held together with duct tape, wheelchairs that were woefully old and causing neuropathies. So what we found was a large population, right? They say at least half of our folks that came to us had really been lost to the medical community for quite some time. And I think there are two reasons for that. One, that many of these folks felt like the medical community really had nothing to offer them after going to maybe back to their doctor every year, every couple of years, and being told, you're getting weaker, but that's all I have for you. They eventually stopped going in to see their provider. And then there was another group that really had very negative experiences with the medical profession in childhood. So I have one gentleman who has a vivid recollection, and he's about close to 40 now, but vivid recollection of being 12 years old and sitting in the neurologist's office with his father and being told what his diagnosis was, that there is no cure, and we expect you'll likely be dead in 2 years. So, that's a harsh thing for anybody to process, much less a 12-year-old. And a lot of these kids that are folks that are in their 50s and 60s, when they were diagnosed, it was through muscle biopsies, multiple EMGs, and really traumatic diagnostic tools that left a lasting impression on many of them. So I think many of these folks kind of had given up their trust in the medical community, and it was quite a deal for them to come back and seek treatment again. So the thing that I think is important to us to express to all these patients is that when you come back to us for this Spinraza treatment, it really shouldn't be just about getting millions of dollars worth of treatment. It really should be that we're going to treat the entire patient, because we all know that there is a lot to offer patients besides treatment. And there's good evidence that being followed in a multidisciplinary MDA care center offers better health outcomes for folks. And if this is at all possible, we have a neurologist, pulmonologist, physical therapist, occupational therapist, speech therapist, dietitian, social worker, genetic counselor, all available in our clinic. And I think the psychological support is an important aspect of care for the adult who has lived for many decades sometimes even defining themselves by their disease I'm losing my words here, but for them to turn around and begin to come back to the medical community and seek care again has really had a big psychological bearing on a lot of our patients. I would just go back and say I think there are two aspects to the health management of the adult with SMA. One is the treatment aspect, and then the other is what I just mentioned, the disease management. So Dr. Sampson and I are actually going to divide our talk up. I'm going to focus on disease treatment, and she'll take over with the management of the adult. So disease treatment obviously is about Spinraza. It remains the only FDA-approved treatment for SMA for adults, living with SMA. What it requires in our program was a lot. It's a difficult program to get started. We had to have a team of neurology providers that were dedicated to treating SMA, because there are a lot of increased people hours in performing assessments, baseline assessments, follow-up assessments. We try to do every 4 to 6 months. We're getting authorizations, prior authorizations. I think someone mentioned earlier 12 hours in the beginning trying to get a prior authorization. Sometimes I think it's easier now for adults, and then I'm thrown by the largest payer in the state denying again for some ridiculous reason. So a lot of man hours during prior authorizations. There's complex scheduling for a lot of these folks, and then actually performing the injections can be quite time consuming. Institutional support is something that was really essential for us. The institution had to assume the risk of getting this really expensive drug. And that when there's no clinical data that it is effective in the adult population, that's been quite challenging. If you're fortunate enough to have never had to deal with procurement of drugs, I'll just fill you in a little bit. Our options are buy and bill, in which the institution buys the drug on its own, bills the insurance company, and hopes to have reimbursement, and sometimes at a profit. The other option is to procure drug through a specialty pharmacy. So the specialty pharmacy will buy drug, have it delivered to the institution, and then they try to get reimbursed for it. So it's nice to have this options with Spinraza, given its expense. And I think for us in our center, a combination of the two has really been useful. The other thing that was essential for us really was a team of neuroradiologists also dedicated to treating SMA. So Spinraza is expensive, $125,000 per dose. Who pays for it? We have found a number of commercial payers that cover Spinraza, usually begrudgingly, but they do pay for it over time. This may require lots of authorizations and appeals. Government payer, this is something that's important for folks to keep in mind as kids transition from the pediatric population to the adult, and may be on other types of insurance to take a look at what will allow them to continue their Spinraza treatment as they age. The government payers that we have found, Medicare has been actually quite good. Straight Medi-Cal has paid for many of our adults, and even some of the managed Medi-Cal plans have covered Spinraza. In some cases, the manufacturer has offered free drug for those that have been denied but have an active appeal pending. So setting realistic expectations was very important for this group. In the beginning, obviously, we had no idea what the expectations were for the adult population. We started by saying our hope is that Spinraza will halt the progression of disease. And I think that now, almost 3 years later, we can say that that's still a very realistic expectation. We have had patients that have shown gain, but not all patients have had positive outcomes, or gain rather. I think every patient that we have treated, we've had 38 adults on treatment now, and they've all had certainly stability of disease, and the majority of them have shown gain. But there's so much variability in what you start with, and so I think that's the most realistic expectation we can set for them. I think part of that is, obviously what their baseline strength, but also what they put into the program, the amount of physical therapy and exercise that they do. So now what I tell patients when they start is that we expect nusinersen to halt the progression of disease, and it may allow you the opportunity to build muscle mass and strength, but it does take work. We also needed to have a great expectation, or set the expectation of what we would like the patients to do, which is if you commit to nusinersen or Spinraza treatment, make sure you come back every 4 months for your injection. We like to see our patients back every 4 to 6 months for a full physical therapy assessment, and the expectation is they really do put some work into this and apply themselves with physical therapy and exercise. The process for authorization, most of you are probably familiar with this. Many payers do have stated policies on eligibility both for loading and for maintenance therapy. There's not a lot of medical rationale for most of these policies, but that is what it is. At least you know what you're starting with. I have found that even some that had policies in the beginning don't often uphold these policies when they're authorizing treatments, especially for maintenance therapy. One of the largest payers in the state just denied coverage for one of my patients who had been on treatment for 2 years with clear success because they said he has more than 2 copies of SMN2. That it was just determined, which clearly he's always had more than 2 copies of SMN2. So here again, this is what we've all been speaking about today, the kind of clarifying what that means to have 2 copies of SMN2 versus 3 or 4 or 5 copies. Are they saying he's too strong for treatment or he's not weak enough for treatment? So in any case, we start with the prior authorization, which may lead to either a denial or approval. So you appeal if there's a denial. Usually a peer-to-peer process takes place, and what I have found is generally the peer-to-peer is just the dermatologist who's kind of upholding the stated policy of the payer. They don't oftentimes have the control of actually saying, okay, we're going to cover it anyway. Then they either decide they'll treat it, approve or deny. You go through a second level of appeal, and then sometimes we even go to a third level, which is a request for an independent review. We've done this with a couple of different payers now, and in both cases they have overturned the denial. Procedural approach is part of the complexity of a Spinraza program. You can see a few different images that we have here, some without spinal hardware, some with a couple sets of spinal hardware. We usually start with a CT scan of the spine, and we have, again, the neuroradiologists who are excellent and very helpful in reviewing the imaging to see if there's any point of access at all for a lumbar injection. And then Dr. Shea talked a little bit about some of the different approaches you have. Lumbar, I think, is ideal since that's how we know Spinraza has been studied. We have quite a few patients that are ambulatory and non-ambulatory who are able to have traditional blind lumbar punctures. The next step, and I think with each level down, we have a little increase in the risk that's added, but we have fluoroscopy or a CT-guided intralaminar lumbar puncture. The next approach would be the CT-guided or fluoroscopy-guided transforaminal lumbar puncture, and you can see, let's see, does this work? The needle on top is the intralaminar, which is pretty straightforward. It's what we're used to with most lumbar punctures. The transforaminal approach coming in on the side into the foramen obviously has to go through more soft tissue, so that becomes a little more painful, and there's more risk with nerve roots and vessels there. Some folks have used ultrasound-guided lumbar punctures, but we haven't really found much success with that in our center. Cervical approach, as Dr. Shea mentioned earlier, has been tried in a number of places across the country. There's obviously increased risk with that, particularly with repeated injections, and we actually don't have a lot of good drug data on how Spinraza works when it's injected into the cervical spine. Some folks have used an intraventricular catheter system. Again, we don't really have data on what the drug looks like when it's administered directly into the ventricle. And with the placement of any kind of catheter system like this, there is general anesthesia that's involved. Most of our adults living with SMA, particularly the ones that have a lot of that have spinal hardware or severe kyphoscoliosis, also have compromised respiratory status. So they may have a forced vital capacity less than 30%. And that's a big factor when you're trying to decide whether they should undergo general anesthesia in order to get a treatment. Surgical approach, some folks have done the hemilaminectomies, laminotomies. Again, a good idea, but you have to undergo general anesthesia, and we really don't know what that opening that they create. We don't know what that looks like after multiple injections and years down the road. We don't know if it closes over or what. A few folks have mentioned, I think Dr. Darris and Dr. Shea have tried a couple of different approaches that are similar to this one that was published by Krauss in Strasbourg, looking at kind of a novel piecing together of an intraventricular catheter and the implantable Mediport. So the catheter is secured into the thecal space and then attached to the Mediport. The Mediport is then routed around to the thoracic spine and attached there. It's an interesting idea, and it's worked quite well from what I understand in other places. You have the anesthesia risk for the implantation of the device, but once it's implanted, it should result in really quick, minimally invasive injections that could be done just in the office at a huge cost savings. So I think this is an area that really warrants a lot more research. When I was trying to review at Stanford here, we've only done a couple of different approaches. We've been quite lucky to have neuroradiologists who are very skilled in getting an interlaminar fluoroscopy-guided lumbar puncture. But I know that folks have had to try a number of different things across the country. There's really, I think I found around like 124 articles published just in the last 2.5 years on interlaminar approaches for the injection of intrathecal approaches for the injection of nusinersen. Most of these were just, case studies or observational studies with a really small sample size, but it speaks to the need for finding these approaches to treating patients intrathecally. And I think that the need's going to continue with other neurodegenerative diseases and other therapies down the road. So somebody needs to start working on this a little more closely. Regardless of what you choose, for each patient, you should really weigh the pros and cons, and there should be some overall clinical expertise in any approach that's chosen. It may be that the interventional neuroradiologist is not the best one to do a transforaminal LP. It may be that the pain doc who does epidural procedures is the one that has the most expertise in transforaminal approaches. So for continuation therapy, subjective data is always wonderful to include. I can open my mouth wide enough to bite into a hamburger now. I can lift my kids over my head now, or I've begun to be able to use a pen to write again. Really, heartfelt, wonderful stories. But ultimately, payers really base their decisions on their objective patient outcomes. So, and for this part, consistency is really key, and this is where the physical therapists really play such an important role. It's so important to try to reduce as many variables as possible, if at all possible, having the same physical therapist performing the baseline assessment, and then each and every one of the follow-up assessments is really critical. If it's done in the chair versus the mat, then you always do it in whichever position it was in. So really just trying to eliminate any of those variables and replicate the assessments as much as possible is key. It's also important to collect data so that we can show efficacy. We've done that at our center, and it's a tough thing to do because we're not talking about research. We're treating patients clinically, so they come back when they're able to come back for assessment. Sometimes they've flown in and they're tired. Sometimes they've driven in. Sometimes they've got a cold. There are a lot of things that we can't account for when we're collecting this data clinically. But I think it's important to do it anyway and make sure we're publishing what we can to prove to not only payers but other health professionals that Spinraza is a worthwhile treatment for adult patients. Spirometry is actually, I think, a very valuable outcome measure to track in the adult population. We've seen gains not only in forced vital capacity, but MIP, MEP, and peak cough flow as well. And that's one that I think is a little easier to streamline and eliminate outside variables. Exercise and PT to maximize treatment are really strongly recommended, and I think they have an absolute impact on how patients fare. So, tolerability and monitoring. So the most common side effect of any lumbar puncture, obviously, is the post-LP headache. The statistics are as high as 25% of patients will get a post-LP headache. There are a few things that we can do to try to reduce that. And then there's also data that the folks that are going to get post-LP headaches are thin females that are already migraineurs, and that there's really nothing we can do to reduce that risk. I oftentimes use an atraumatic needle, which supposedly reduces the risk to about 5 to 10%. The folks that are going to get these headaches, we've treated some now 12 times, so they know what works and what doesn't, and they often tell me that caffeine works. There's not great data to show that caffeine works to prevent a post-LP headache, but I go with it because it seems to help them. That's what they believe helps them. So they usually leave my clinic and go get a giant coffee, and then I tell them also stay really well hydrated, because why not? If you do have patients that develop a post-LP headache, which can come, right away or days afterwards, and if it continues, you may consider the MRI to look for meningeal enhancements or a sunken cella syndrome due to low pressure. I have not had to refer any patients for a blood patch yet, and we've had close to 300 injections, I guess. The difficult IR procedure, there are a few things that you can do to try to make this easier. One is simethicone, just to reduce the bowel gas. During fluoroscopy, you can the images that the openings that they're looking for maybe 2 or 3 millimeters big. So to have bowel gas covering it 1 minute, and the next image has your 3 millimeter opening is gone, is quite worrisome. So reducing bowel gas is an important part of that. We always tell folks to remain hydrated. Some of these patients have their access point may be at S1, S2, so it's really where the thecal sac is probably tapering there, and it may even close up on itself or adhere to itself. I don't know that hydration makes a difference, but it seems to. So we ask them to remain hydrated before they come in for procedures. And some folks do require a little anxiolytic if they're really nervous about it. In the adult population, we don't provide any sedation for lumbar punctures. Some folks that are getting transforaminal approaches in the cath lab may have sedation, but in our center, we haven't had that need yet. The drug itself is well tolerated. We monitor for bleeding and kidney complications, which have been seen with other drugs of this class. I haven't had any patients that have had abnormalities other than a couple of low platelet counts that were transient and did not require halting treatment. And then routine labs for the CSF, which I don't send in with each injection. But so other parts of treatment, Dr. Shea, I think, mentioned some investigations of small molecules. Here are some other treatments that have been tried in the past, agents that have shown potential benefit, but then did not really pan out in showing benefit in randomized clinical placebo-controlled trials. Albuterol, however, is probably the one that's been the most studied and of the older agents and has the most potential of the older agents. Not really sure why albuterol works. There are hypotheses. It's been used to increase strength in other neuromuscular disorders. There's some belief that it inhibits the SMN degradation. I really like the idea of the neuromuscular junction impairment in SMA, and that albuterol may have a role in that. And the reason I say that is because so many of our patients had subjective reports of great improvement after Spinraza almost immediately. Within 2 days, they had some type of improvement that didn't seem to make sense. So I think that's an area that we really need to investigate further. And then there's a hypothesis that there is selective improvement in the inspiratory respiratory muscles in SMA that albuterol helps with. Who benefits from albuterol? It's hard to say. The responses are very subjective and variable. Some folks will say, I have more endurance and I like it. Others don't even take it on a regular basis. They may just take it on a daily basis. If they have a lot of activities for the day, they may take it for that one day and then and not take it routinely. There is some evidence that, or some suggestion that folks with more copies of SMN2 have a better response to albuterol. But it's very well tolerated in most patients. Obviously, the side effects can be tremor, nervousness, and tachycardia. But I think probably about at least 50% of our adults do take albuterol on a regular basis and find that it's beneficial. So with that, I will turn it over to Dr. Sampson to discuss the management of the adult.
Hi. So I'm just going to build on some of the things that Connie talked about and a little bit more about the setting, not just the treatment, but the overall health that will help optimize those outcomes. One of those things is making sure we have a good transition of care. One of the things that Connie really eloquently described is how we have lost track of our patients in the past. And part of this is because we don't have the adult teams to take over their care, and part of it is that we haven't prepared the way for transitioning them to adult care. And I feel strongly that this is an important thing for our patients because we want to send them the message that we expect you to become an adult and we are going to treat you as an adult. And in order to do that, we need to give them a medical home. And so one of the first things that we need to do is to kind of start preparing the way for that. And this is why it takes a village to do this, and sometimes even an army. And one of the most important people in this process can often be our social worker. We need to talk about everything from insurance to caregivers to school to employment to what happens when your parents age. So this is something that really is a lifelong process. Because the time to meet your new adult team members is not when you're in the emergency room or you're about to have a surgery. They're not ready, you're not ready, it doesn't go well. And so we want to try to build a world where we have adult clinics to take care of our patients. So when do we make this transition? So it's going to depend a lot on your resources locally, the physicians who you'll be handing off care to, and even, nuts and bolts like insurance. There are going to be some boundaries for age as to who will treat who when, and some of those have some elasticity on the pediatric side. I know there's pediatric cardiologists who are treating 50-year-olds, but not every discipline is going to go with that. So when you're splitting care across two sides of the bridge, adult and pediatric communication can sometimes break down. So I think it's important to build these bridges, improve the communication across the adult and pediatric bridge, and have this be a process. So it doesn't have to be all at once. Here in California, as I said, as you become an adult, things like insurance and those practicalities change. So for example, CCS, when it finishes at 21, making sure your DME is all updated, repairs have been made, wheelchairs have been replaced, everything's been optimized before you make that leap, often can be very helpful. So it's a bit of a chess game to get that done. So the when and how of planning should start early. We recommend around 17, but you need to be talking with your patients earlier than that about their diagnosis and their understanding of it and what their thoughts and wishes are as well. Depending on the parents' employment, many young adults can stay on their parents' policy until they're 26, and in some places you can get an extension on that through human resources for qualifying disabilities. When you change to adult care, you might be changing providers, and those providers might not be on the pediatric insurance. So looking during open enrollment to make sure that your destination pulmonologist or cardiologist takes the insurance that you're moving to or have is important. And then talk with your social worker about things like your Social Security disability benefits and how they work with your health insurance. So some of these things are more California relevant than across the nation, but I'm referring you to useful websites for that. So open enrollment is always a good time to kind of take an overall assessment of things, who and what hospitals are contracted, and don't be afraid to ask concrete questions about things like prior authorizations for appointments and treatments. And again, some more resources for that. Also talking with other parents and families, their experiences. They often know who the best contact is, or they have a case manager who's been really great. And in your local community, that can really smooth the way for families with younger patients moving to adulthood is growing with that experience. So that's some additional information about that. And so as you're moving to the adult clinic, the focus is primarily on the patient. They have parents, they have caregivers, they have relatives, but we really want them, as everyone has said all along, this to be patient-centered and for them to be taking increasing control of their health care management and decision-making. We want them to be as independent as possible and to be the ones directing their care. And this also means asking them about their opinions about hard choices. These are intelligent young individuals. What would they want if, fill in the blank, there was an emergency or intubation or surgery required, and giving them the information they need to participate and make those decisions. And asking them questions about advanced directives. As Connie said, many of these patients have been lost to follow-up for years, and they have had negative experiences, and they have, they have from their own experience know what they want from their health care, and to listen to them and respect that and incorporate that in their care, because we don't want to lose them to follow up again. And for a lot of that, it's asking decisions about end-of-life care and emergency situations. So one of the major things that I'm going to switch gears a little bit now and talk about the other healthcare maintenance. And next, just due to the order of things, is going to be Oscar and Mimi talking about pulmonary care. And I feel like that is one of the most important aspects of caring for an adult with SMA to help optimize their outcomes, whether they are on treatment or not. And I'm not going to steal their thunder any more than that, other than to give a shout out about vaccinations, not just for children's, and it's not just the flu shot. They need to have their Pneumovax vaccination, which adults who have been lost to follow-up probably haven't had, and they probably also need a booster for pertussis, because pertussis is made recrudescence, and that's not a great thing. And it's a really severe illness if you're also suffering from or also have SMA or any respiratory difficulties. So checking on the vaccination. We don't think of the heart as being primarily involved in SMA, and there are reports in SMA1 of some developmental anomalies occurring. But in SMA2 and 3, there are also reports of bradycardia and heart block, atrial fibrillation, and flutter. I would just say, remember that these are individuals that are adults and they're aging and they are susceptible to the same slings and arrows of every other health problem as every other American. And to pay attention to that. Also, that you need to consider how the musculoskeletal effects of SMA are affecting their cardiopulmonary health. They have a restrictive respiratory pattern and hypoventilation, which can lead to pulmonary hypertension. It was interesting to me that in one retrospective hospital series, almost 15% of adults admitted with a hospital admission for spinal muscular atrophy had comorbid hypertension, not just elevated blood pressure on admission, but hypertension as a comorbid diagnosis. And as Connie described, many times this has been left completely uncontrolled because the general internal medicine and primary care philosophy was that if these people were not expected to survive long, why are we doing aggressive treatments? We are expecting them to live, and we want them to live well. And in order to do that, we need to take good care of all of these aspects. Another often untreated comorbidity is lower extremity edema. And much of this can be due to dependent edema, decreased venous return. It puts you to an increased susceptibility for cellulitis, DVTs, and also it's just uncomfortable. So paying attention to things like this is very important for them as well. As we heard earlier, with the children with SMA, GI function is impacted, so swallowing and chewing are both difficult in many adults, 24% in one series. This leads to an increased risk of aspiration and hospitalization for aspiration pneumonia and choking episodes. It affects their food choices and their consumption. They may not be eating the more difficult things to chew and swallow of fruits and vegetables with a lot of fiber, and might be limiting their nutritional intake. And so we recommend regular assessments by speech therapy and also nutrition. They may already have a G-tube or they may need one for enteral feeding, and you might be taking on some of their primary care management issues and be managing their reflux, managing their constipation as part of their global care. And in that same retrospective chart review, diabetes had fairly common in about 6% of the individuals in that study. One of the things I wanted to emphasize was the importance of nutrition, and I have to, again, point out that this is work done by Dr. Darris and other members of the community sitting in the audience, but nutrition is really very important in the adults as well as in the children. We always worry about hypoglycemia and ketosis when they're put on a prolonged fast, which might be before they have their sedated intrathecal injection. But there's a lot of difficulty in maintaining an optimal weight. In this paper by Dr. Martinez is that 45% were either overfed or underfed based on a mismatch between their caloric intake and expenditure. And many were deficient in vitamins D, vitamin E, K, folate, and calcium. And vitamin D levels were suboptimal in 29%. So we recommend medical nutrition evaluation for all our patients. I think Julie already spoke a fair bit about bone health, and we've heard from the mic our concerns about that. If our muscles are going to be getting stronger, then we need to have the bones that they're working against stronger as well. As children are ambulating, then we need to worry about their risk of fall. And you look back through children's charts and adults' charts, and radiology is using words like gracile. Gracile to me, it really means, boy, they look like they're very fragile and going to fracture. And it's not a very scientific term, but gracile also means that developmentally their bones aren't normal. I don't think it's simply disuse, and there are some papers in the literature about bone development in mice, and that the SMN protein does interact with an osteoclast stimulating factor. So there may actually be non-nerve, non-motor functions of SMN in bone development and maintenance. But I thought this graph from the Wasserman paper was particularly eloquent in describing bone density in spinal muscular atrophy. You can see that it's only the SMA3 individuals who even graze the 2 standard deviation gray range. The rest of them start low, improve a little, and then it's all downhill from there. In adults without SMA, your peak bone density is when you're 30. You can see that they're starting to trend downward even earlier than that if they aren't optimizing their bone health in childhood. It isn't getting better in adulthood unless we're, finding better ways of treating this. So asking about pain, asking about fractures, I think is still very important. Just to conclude, pharmacologic care is only part of the picture. Multidisciplinary care is the foundation that these new therapeutics can build on, thinking of it like the setting for a gem or a frame for a picture. One without the other is not the whole story. And adults suffer the long-term sequelae of pediatric manifestations of SMA, and you add to that normal aging. And as life expectancy increases, therapeutic response expectancies increase as well, and the complexity of their care. And they need a home. They need someone to captain that ship and to coordinate their care and make sure that the other physicians who are caring for the children who have now grown up, the children who lived, have someone who are qualified and able and interested in their care. And that's our job, is to build those teams.
So what do insurers consider a meaningful outcome or result for chronically wheelchair-bound adults with known contractures and are dependent at baseline?
I can answer that. It's anybody's guess. It really varies. I've had as I said, some payers will have their stated policies on what requirements need to be met to have continuation therapy approval. United Healthcare, for example, wants a 2-point gain in CHOP INTEND or Hammersmith or Heine. Others are not as specific as that, but I say overall stability of disease is not something they would consider for continuation therapy. I've even seen a variance within one payer, Anthem Blue Cross, the largest payer in the state of California. Depends on the actual policy. One policy they may pay every time, and as I mentioned earlier, another gentleman who's been on treatment for over 2 years with great gain, ambulatory patient, all of a sudden they decide, well, if you have more than 2 copies of SMN2, we can't treat you. You're too strong. You really don't warrant the expense, right?
I was hoping you might let me get up on a soapbox and add to this transition point. So thinking about these kids who live, who are supposed to die, it's usually their parents who are the ones that have received the genetics information. Mm-hmm. It's not usually those kids themselves who have received that. So another piece of transitional care would be educating the patient themselves about genetics and reproductive options.
Absolutely.
I will get off my soapbox.
Absolutely. Thank you. Thank you, Carly. That was a great addition.
One other question, I'll combine a couple, is what are the functional PT goals for ambulatory patients with SMA? And then are there concerns about overworking muscles during exercise? Some of these might be better done tomorrow with the physical therapist being more front and center, but I don't know, do either of you want to take a crack at it?
It's a hard question to answer. What are the goals? It depends on where the patient is, where they started, and what they've acquired through treatment. But it is a question we get from every single patient. What should I be working on, and how should I get stronger? And we need our physical therapists to come up with some great goals for us. We oftentimes will kind of pick one small functional goal. Maybe, if this functional activity is really difficult for you and we think it's within reach, why don't we work on this? And you go to your outside physical therapist and tell them, this is the activity that I would love to be able to do. If I could just roll over in bed, it would be great. It would help me in so much in my life. So I will oftentimes ask them to come up with a small goal and take that to their physical therapist and focus on the muscles that they might need to perform that task, and then move on to the next one. It's never going to be going from my wheelchair to walking, obviously, but if you pick a really small goal, it seems to hopefully be attainable.
And my philosophy has always been the start low, go slow approach, that if they dive in and do the most strenuous thing first, and they're injured or achy the next day, their chances of coming for the second visit are really low. But if you give them small successes, then they're engaged and they're going to stick with the program, and it will become part of their lifestyle. So I think, avoiding the injury and giving them those successes and victories that give you that positive feedback to stay engaged and active is really important. I mean, think of people who don't have SMA and how many gym memberships go by the wayside. This is human nature. This is not unique to SMA to not, be able to stay with a physical therapy or other plan. So we need to treat them like we do all our other patients, that there's going to be ups and downs and compliance and non-compliance, and to be merciful and forgiving to our human frailties.
I would just add to that, the concept of exercising to stay healthy and to build muscle is really very novel to these adults in the 5th, 6th decade of life that have SMA. They've never exercised in the past, and they don't know how to do it.
And often they've been told not to.
Exactly.
And so they've been given this deterrent to being active at all. And so I think
kind of changing that mindset is the first step.
Excellent. Thank you very much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.